Welcome and thank you for standing by. At this time, all participants are in a listen-only mode for today's call. Now I'd like to turn the meeting over to Vidisha Sinha. Thank you. You may begin.
Hi, everyone. Thank you so much for joining us today for the first episode of the Tobacco-Free College Campus Initiative's webinar series. We will get started in a short moment here. I do want to remind everyone we recommend that you use Chrome or Firefox to open up the webinar portal, the live meeting. Internet Explorer may not be the best option for this. So if you are using Internet Explorer and having trouble, again, we recommend that you join via Chrome or Firefox. So thank you again so much for joining us for the first episode of the Tobacco-Free College Campus Initiative's webinar series. My name is Vidisha Sinha, and I'm an ORS Fellow for the U.S. Department of Health and Human Services within the Office of the Assistant Secretary for Health in Region 5. And I had the pleasure of moderating today's webinar. For those of you who are not familiar with the Tobacco-Free College Campus Initiative, or TFCCI for short, we will have a brief introduction to the initiative later in the presentation. Today's webinar is titled Women and Tobacco, Why Gender Matters, and we have gathered a remarkable panel of experts for you who will present various related and interesting topics. Before we begin, just a few housekeeping notes. We will have an official Q&A session at the end of the presentation when we will attempt to answer as many questions as possible. You may submit your questions throughout the webinar using any one of the following ways. You can submit your question via the Q&A tab at the top of the live meeting webinar platform. The second and most encouraged option is sending your questions via our Twitter handle at TFCCI, or you may text your questions to 412-438-3224. If your question is for a particular speaker, please do indicate that in your submission. And I also just want to mention that the webinar will be archived, and the information for the archive will be shared with you via email soon. I'd like to begin with a brief overview of today's agenda. We'll start with opening remarks from the Assistant Surgeon General, Nadine Simons, followed by Maria Perno Goldie, who will share how smoking and tobacco use pose a serious risk of death and disease for women, as well as the effects of tobacco use on the oral cavity. Next, Jean O'Connor will describe her efforts to use data to better understand demographic and geographic patterns of maternal smoking and attempts to quit, as well as the challenges encountered in reaching the population of women who smoke for the entire duration of their pregnancies. Following that, we will have Michelle Hirsch discuss the connection between stress and trauma and how we can address smoking cessation through coping and harm reduction. Last but not least, we will have Emily Claymore briefly present the Tobacco-Free College Campus Initiative and bring your attention to some resources that are available through TFCCI. Now I have the honor of introducing Assistant Surgeon General Nadine Simons, who will provide today's opening remarks. Rear Admiral Simons is a nurse in the U.S. Public Health Service Commission Corps and was appointed Regional Health Administrator in April 2011. Prior to this appointment, she served as Deputy RHA for 7 years. She also served as the Regional Program Consultant for the Office of Population Affairs in Region 9 for 5 years. She began her public health service career in 1987 as an occupational health nurse consultant with Federal Occupational Health in Region 5 and has held various regional and national leadership positions in the Chicago and San Francisco regional offices. Welcome, Rear Admiral.
Can you hear me?
Yes.
Can you hear me? Okay. Thank you. Thank you, Vidisha. Thank you for that nice introduction. And I'm Nadine Simons, and on behalf of the HHS Regional Health Administrators and their staff, I want to welcome you all to today's webinar, Women and Tobacco, Why Gender Matters. Well, before joining the U.S. Public Health Service, I practiced as a clinical nurse for many years, both in the U.S. and abroad. It was during this time that I witnessed firsthand the horrific health conditions tobacco causes. No matter where I worked, in hospitals, clinics, workplaces, or schools, the devastating effects of tobacco use were everywhere, and all of them were completely preventable. Because of this experience, the topic of tobacco prevention is of particular importance to me, especially when it comes to women's health. As many of you are aware, last week was National Women's Health Week, May 10th through the 16th. Mother's Day kicks it off every year. And this annual observance serves as a time to help women understand the steps they can take to improve their health and to empower them to make health a priority. And we know women exert a huge influence on the health decisions of their family members. Today's webinar will reinforce that the best steps a woman can take to improve her health is either never to start or to quit smoking. While smoking harms and kills both sexes, killing approximately 480,000 people a year, women face unique and even greater health risks from smoking than their male counterparts. Today, nearly 20 million women in the United States smoke cigarettes, and more than 200,000 American women die every year of smoking-caused diseases. To create a tobacco-free generation, we must engage and empower women to protect and advance their health and the health of their families. We have the tools to make this a reality, and I look forward to hearing from our speakers today who I know share this vision and goal. Thank you all for joining us today.
Thank you so much for your remarks, Admiral Simons, and for being here. Next, I'd like to welcome Maria Perno Goldie. As a noted researcher, author, and speaker, Maria has presented seminars nationally and internationally on topics such as women's health and wellness, cancers and oral care for the cancer patient, oral cancer, enamel therapy, and immunology and periodontal disease. Maria is a member of the National Advisory Committee for the Robert Wood Johnson Foundation's Smoking Cessation Leadership Center. Maria also served as the 1997 to 1998 president of the American Dental Hygienists Association and the president of the International Federation of Dental Hygienists 2010 through 2013. Maria, over to you.
Thank you very, very much for that. I would like to thank the Tobacco Free College Campus Initiative and Joshua for the opportunity to be a part of this illustrious panel. I am very honored to be a part of this. As you probably all know, we really do have an epidemic of smoking-related diseases, especially cancers in women. 600% increase since 1950. In those days, women saw cigarettes as symbols of freedom and a sign, that they are their own person and that they have gone beyond the roles that society has kind of put out for them. We also know that smoking is the most prevalent way of tobacco use, though not the only way. All kinds of tobacco use is not healthy, is not good, but smoking is particularly bad. The tobacco companies want us to believe, especially women, that if you smoke, that you are sexy, that you're attractive, that you have your own mind. But that obviously is not true. Aside from the health issues that we have, there are a lot of aesthetic issues as well. And I know I live in California, and you are certainly a persona non grata in many places if you smoke. It does cause many things, especially things like wrinkles, odors, not to mention yellow teeth and things of that nature. People that smoke actually have a unique set of wrinkles. It's called smoker's face. The wrinkles are much deeper than ordinary wrinkles, especially around the mouth. And this is because smoking interferes with circulation of the blood and also impairs wound healing. So this is a very serious issue that women may listen to because most of us are pretty vain. Again, the tobacco companies would have you think that you've come a long way and that if you smoke, you'll be more attractive, when in fact, you will actually age faster and die faster. The other thing we see is that in the United States, ads are targeted also for ethnic minorities. Virginia Slims, as an example, features a beautiful Asian woman or women in different ads and tells them to find their voice so that they will actually go against some of the mores of their particular culture. So we see that this is happening over and over again. Virginia Slims started in 1960s, and they capitalized on the feminist movement and how far we have come. And a lot of times when you see their ads, you will see ads side by side where we were 100 years ago. They also featured these ads in places like Japan and other places around the world. And if you go to the UCSF library, you will see documents related to the smoking behavior of women that were compiled by the tobacco companies, where they have really studied the habits of women, and they realize that women are supposedly more motivated to smoke than men, and they find it harder to quit smoking. As well, they feel that women are more neurotic than men. How do you like that? They target people women in particular, females that are young, between the ages of 18 and 20, no education beyond high school, and entry-level jobs. So they actually had a whole campaign around the Virginia Slims brand where they wanted to make sure it was very feminine, suggesting romanticism, and making them look slim and attractive. So why do people smoke? Even when you look at young people, 72% of 12th graders do not want to date someone that smokes. They don't want to kiss smokers either. So hopefully this will keep people from smoking or beginning to smoke. We know that cigarettes contain a lot of awful things that can kill us, and we also need to keep in mind that nicotine, which is the main ingredient, is what hooks us and addicts us. When we look at health-related issues, we can see here that the lung of a smoker and a non-smoker, I think the picture is worth 1,000 words here. So smoking not only affects your lungs, which of course that makes sense, but it also affects our arteries and our hearts, our whole cardiovascular system. So keep in mind that just because the smoke just reaches, your head and neck area and your lungs, that it affects the entire immune system and affects all kinds of issues in our body. So some of the issues that are unique to women, over 1.5 million teenage girls smoke cigarettes. And there are specific consequences to women. As an example, according to the Surgeon General's report, some studies suggest that cigarette smoking may alter menstrual function, as you can see on this slide. Women smokers reach natural menopause at a younger age than those that don't smoke, and can cause things as well as damaging the quality of life and other complications. We can also see here that if you are trying to stop, or if you're a healthcare professional helping people to stop, take into account the menstrual cycle. Commonly reported symptoms of smoking withdrawal are depression, irritability, anxiety, lethargy, and things of that nature. Because 70% of women experience premenstrual syndrome that have the same symptoms, the additive effects may be a problem. There was one study that shows that women that quit during the luteal phase, which is ovulation 1 day prior to menses, actually experience greater withdrawal than women who quit during the follicular phase, which was day 2 to 15. So just keep this in mind if we are trying to quit ourselves or trying to help somebody to quit. The other thing to keep in mind is that if you're trying to conceive or know people trying to conceive, there is less fertility, so you may not be able to become pregnant quite as easily. Also, the risk for perinatal mortality, stillbirth, neonatal deaths, are SIDS and things like that are increased among the offsprings of women that smoke. However, women who quit before pregnancy definitely reduce their risk of these adverse outcomes. Menopause is a normal part of our life cycle, but as a result of hormonal changes, women may experience greater difficulty with weight control, changes in body image, and this all has coming around the time where there's a change in societal roles. And this might negatively influence the likelihood of tobacco cessation. So we just need to keep that in mind as well. The other thing that comes with menopause and as we age is less bone density. And smoking has an unfavorable effect on bones. And we need to keep in mind that there's an increased risk of hip fracture, and this is especially important because 10% of people, of women in particular, who will die as a result of a hip fracture. So a hip fracture isn't just a simple broken bone. Also, breast cancer patients who smoke may increase the risk of dying by 25%, and the risk of fatal breast cancer rises up to 75% for women who smoke more than 2 packs a day. Women fear weight gain during smoking cessation more than men do. However, there have not been any real studies to show that weight gain is a part of tobacco cessation, so do keep that in mind as well if you're counseling. But the tobacco companies have wanted to capitalize on that as well, so they wanted to create a brand that was an appetite suppressant, and they wanted to put that particular suppressant either in the tobacco itself or in the filter. So remember that women especially, can have eating disorders because being slender is really something that affects especially teenage girls and young women. So trying to help them get over this obsession with body weight will not only help them, but might stop somebody from having an eating disorder. And you can see some of these ads, and we see some of the parodies on the ads as well. So, and the CDC has wonderful ads that you can use for graphic purposes. There has been an overall decline in adult smoking, so the tobacco industry has moved to recruit young people. And they recruit almost 1 million new smokers a year. Most of them are children and adolescents. They target their tobacco advertising to children and adolescents as well as ethnic minorities. One of the ways they do this is by flavored cigarettes. We see these in BBs, we see these in hookahs, and other kinds of things as well. Young women, more so than men, are more likely to want a flavored cigarette. A little bit on tobacco and pregnancy. I know we're going to be hearing about this farther along as well. But people that smoke normally drink as well, so fetal alcohol syndrome is something we need to be very, very much aware of. Significantly more stillbirths and babies that die during the first month of infancy happen if someone smokes during pregnancy. And women who smoke during their pregnancy may have difficulties delivering, go into premature labor, and all kinds of negative issues. As well, the children of women that smoke have all kinds of issues as they grow up. So it's important to try to help women to stop smoking, especially if they're pregnant.
There you go.
If someone smokes during pregnancy, by the age of 5, children can inhale the equivalent of 100 packs of cigarettes. Now that is saying something. But the good news is that women do quit at higher rates during pregnancy, and a third of those that stop smoking will be smoke-free 1 year after delivery. And there is a smoking quit line, and as I said, you will hear more about pregnancy later in the course. So we want to avoid this kind of issue. I think this smoking room ceiling says it all, and this casket. So graphics is, they do help sometimes. So the point is, it's hard to stop, so don't start. Some of the oral risks that we see, many cancers, certainly, as well as periodontal disease and aesthetic issues such as bad breath, yellow teeth, and things like that. Oral and pharyngeal cancer is very, very serious. It kills about 1 person per hour, 24 hours a day, and only 57% will be alive in 5 years. And tobacco factors into about 75% of all of the cases. There is causal evidence, and there is a link between cancers that you see on the slide, as well as other cancers such as kidney and pancreatic cancers. And certainly, cigars are not a safe alternative. Tobacco companies have been targeting women with tobacco clubs and cigar clubs and things of that nature. But things like cancer of the lip and the mouth also are part of tobacco smoking with cigars. And as we heard earlier, this is sad because all of this could be prevented. So, again, trying to stop yourself or to help someone that you know stop is very, very important. This is an example of a young man. He died at the age of 19 of oral cancer because he chewed tobacco from about the age of 12. So this certainly, this graphic is not something that I think would frighten most young people. So why quit? Adult female smokers lose 14.5 years of their life due to smoking. I think that's a pretty amazing number and reason for quitting. And aside from the health issues that we're talking about, you're free from addiction and you have aesthetic things. You smell better, your clothes are better. You actually are better at sports and things of that nature. And you can find all kinds of graphics online to show that within 20 minutes, things start to happen positively if you stop smoking and continue for 15 years. So there are many, many positive effects of not smoking. 3 minutes or less can save a life. 70% of smokers want to quit, but they will do so more often if they are advised to do so by their healthcare professional. So if you are a healthcare professional, please be sure to ask. I advise you to go to the Smokers Helpline and also to the Smoking Cessation Leadership Center hotline, which has a website with wonderful information that can help you. So let's really try to stop this epidemic, especially in our young people, to stop people from dying and becoming addicted. World Tobacco Day, World No Tobacco Day is May 31st, and you can get more information from WHO or from going to the Tobacco Free Campus website. One last thing, I just read this the other day, that we know that smoking causes DNA damage. Now we're starting to be able to detect it in swabs from the cheek. So hopefully this will help in smoking cessation programs. So I want to thank you for this opportunity. I hope you've learned a little something, and I look forward to hearing the rest of the presentations. Thank you very much.
Thank you, Maria. I just want to remind
Yeah, I think they're having trouble with the audio.
Hi, everyone. Thank you for your presentation, Maria. And Vidisha, if you're on, your line is muted.
can you hear me now?
Yep, we can.
Wonderful. Yeah, I was having a little trouble. Apologies. So Maria, thank you again so much for your presentation. I just want to remind all the speakers, if you're muting, please mute your lines, *6, and again, unmute yourselves when you will present, again, by dialing *6 to unmute yourself. And also, to all the participants listening in, you can send us your questions via the webinar Q&A function or by sending us a tweet at TFCCI and or texting us your questions at 412. There's the number 412-438-3224. Thanks. And next we have Dr. Jean O'Connor, who's the Chronic Disease Prevention Director for the Georgia Department of Public Health, where she's responsible for statewide programs related to cancer prevention, tobacco, adolescent health, and asthma. Dr. O'Connor has worked in public health research, policy, and program development for almost 20 years, starting out as emergency medical technician and doing research in the emergency department at Grady Hospital. Before joining Department of Public Health in 2013, Dr. O'Connor served as a state deputy health director and a health insurance policy advisor and a health scientist at CDC working on policy and strategy issues across multiple centers. Welcome, Dr. O'Connor.
Thank you very much. Well, I'm delighted to be here with you. I'm going to share a little bit about tobacco cessation and maternal health here in Georgia. This is some examples for you. So much like many other states, tobacco is the leading actual cause of death here in Georgia, contributing to more than 12,000 deaths a year. Men are more likely to die than women, and on average, a smoker loses 16 years of life here in Georgia. We heard the figure 14.5 years on average for women. The toll of tobacco here in Georgia, and again, we're very representative of the nation in many ways, with a population of about 10 million people. The toll here is that tobacco costs us about $3 billion a year in healthcare costs. It costs our Medicaid program more than $500 million. The average individual's burden associated with tobacco use is about $550 per household. And we lose about $3 billion a year in smoking-related productivity losses. We're very lucky to have a comprehensive tobacco use prevention program. Our program is focused, like many other comprehensive programs, on preventing youth initiation and use among adults, promoting quitting, eliminating exposure to secondhand smoke, and identifying and eliminating tobacco-related disparities. Our program works with both men and women and youth, but we'll be focusing today around some of the work that we do with women. A few words about some of our recent successes here that we think benefit women in the state of Georgia and beyond. Recently, our Department of Public Health went entirely tobacco-free. About that. Very proud of some of our recent successes here around tobacco-free colleges and universities. This last year, our university system for our state implemented a tobacco-free policy that impacted 31 colleges and universities, protecting almost 400,000 people going on 15 square miles of what are now tobacco-free. More than 50% of the people on those properties staff are women, so that's a great benefit to women's health. It was the sixth and largest public university system in the nation to go tobacco-free.
The passcode you are attempting to enter is 9707171.
For the tobacco-free colleges and
Please confirm your conference information after you're calling in, or call your conference
Connor, if you
leader.
wouldn't mind just interrupting. Please put your lines on mute if you aren't speaking. We have some disturbances online. Again, it's *6 to mute your line. Thank you.
We also have an initiative here to take our K through 12 school system tobacco-free. We have over 100 of our school districts here in the state of Georgia out of 181 are tobacco-free, protecting over 1 million children. We also have quite a number of things going on with providers around asking patients about tobacco use, advising them to quit, and referring them. We're providing guidance to providers, including women's health providers, around cessation services. And in this last year, our Medicaid program, of course, like most other states, added benefits for tobacco cessation support for its members. A little bit about the epidemiology of tobacco use here in Georgia. We ranked 30th among all states for smoking. We have about 1.5 million adults who smoke. This decreased a little from 21% to now around 18%, 18.8% on average. And smokeless tobacco use rates here are high. About 315,000 adults use smokeless tobacco in our state, including women. Youth tobacco use is a serious problem in our state, and while traditional cigarette use is declining, alternative forms of tobacco use are increasing, particularly among girls. Like others, we are concerned about flavoring that targets girls. Flavors like peach, grape, particularly in electronic cigarette products, are being marketed to young women here in our state. You can see here on this next slide just some of the differences by race and by gender in tobacco use. Women are less likely than men, and whites are more likely than blacks to use tobacco products. We also have significant exposure to secondhand smoke. Almost half of adults in Georgia report being exposed to secondhand smoke in one of the last 7 days. And we have disparities in these exposures as well. Low-income persons, and there are differences by race and ethnicity. And this is important when we talk in just a minute about pregnancy and smoking. A little bit about maternal health. Here in Georgia, we have early and preterm births, like many other states in the Southeast, that we consider to be a significant issue. And as you know, tobacco use is associated with early and preterm birth, as well as with infant mortality. We've been very concerned here in Georgia and made some significant progress in the last few years in reducing infant mortality. And what you see here is a map of infant mortality clusters from the time period 2006 to the time period 2010. And you see demographic clusters on the right. These two slides show you that we have a significant amount of diversity in our state, including where we find infant mortality and across demographic clusters. Many people think only of the Atlanta area when they think of Georgia. What we wanted to know was really, were women using tobacco products during pregnancy? And what you see here is a slide that includes PRAMS data. There's really no single source of data related to smoking during pregnancy that we can point to really understand the problem. So we started here in Georgia in our attempts to understand what was going on by looking at the PRAMS data and looking at women who smoked for the entire duration of their pregnancy, as well as the first 3 months or the 3 months before their pregnancy. And what you see here are those two different rates. 15.9% of women smoked the 3 months before pregnancy, and 6.2% smoked the last 3 months of pregnancy. We were curious about this here because we do have a Georgia tobacco quit line. Who were these women, or were they calling the quit line? Our quit line is available 7 days a week, 24 hours a day, in English and in Spanish, as well as other languages. And we know that our quit line is effective. Through an evaluation we did a few years ago, at the time of follow-up 7 months after enrollment, 31% of the respondents who called the quit line were tobacco-free for 30 days or longer at the time of follow-up. So that's almost 1 in 3 persons who used the quit line with NRT who were tobacco-free. The USPSTF recommends tobacco cessation counseling for pregnant women, and as some of you may know, there are new draft recommendations that are open currently for public comment. The new draft regulations propose a grade A now, up from a B, for behavioral interventions for women who use tobacco, and will begin listing pharmacotherapies such as NRT with a grade of incomplete. The prior recommendations didn't provide any information on pharmacotherapies, so we view this as significant progress. What we also wanted to know here in Georgia was who was calling the quit line? Were these pregnant women calling our quit line? So we looked at our quit line data. There we go, got the slide back up, to see how many women who were pregnant or postpartum were calling the quit line. Our quit line, much like in many other states, offers a 10-call module for pregnant women that provides them with extra support. So you see here the number of callers in blue who are pregnant who called the quit line, and we see some significant variation from year to year. We don't have a great explanation for that, but we knew we wanted to address it. So we decided to take a closer look at the demographics of pregnant smokers here in Georgia. Of those women who were smoking the entire duration of their pregnancy, or at least the last 3 months, who were they? How could we better target them and increase our calls to the quit line? We have an estimated 10,000 women a year in Georgia who are smoking for the entire duration of their pregnancies, and we consider this to be very significant. About 1 in 3 of those women, and this is somewhat surprising, it was surprising to us, are ages 15 to 24. So these are very young women who are smoking during pregnancy. About 1 in 5 are aged 24 to 29. And these women are less likely to have a college diploma or have had prenatal care in the first trimester. And they have low rates of prenatal care in the second trimester. They also live in areas of our state that have high tobacco use rates overall. And 44 rural counties had maternal tobacco use rates of above 12%. White women were more likely than black women and more likely than Hispanic or Asian women to be smoking in the last 3 months of their pregnancy. And through looking at PRAMS data as well as vital records data, we discovered as well that these women's household income was under $24,000 a year, some under $10,000 a year, and they were more likely to be unmarried, have an unintended pregnancy, and use WIC than other women. We use this information to target media in May of 2014. We used existing tips messages from CDC to target 2 audiences, men who might live with these women, and then women, younger women. We also conducted a satellite media tour with our commissioner, where media from all over the state were invited to speak with our commissioner, who's an OBGYN, to talk about the risks of smoking for pregnant women. And this year, in April, sorry about that. This year, in April, we ran additional media in the counties with the highest maternal tobacco use rate. And we used the Amanda message, which you see featured here in graphics, via radio and in print in the Columbus area, Rome, Waycross, and beyond. And we ran about 10 to 20 messages a week. We spent about $20,000 in this campaign. And while we're still working through the data, we believe that based on the calls we've received from this campaign, that we have been able to avert, by spending this $20,000 in these areas, about $750,000 in healthcare costs related to preterm birth. So we're very excited about the potential return on investment in this area. And as next steps, we're going to be continuing to work in a number of areas, such as tobacco-free hospitals. We're going to be working with rural dental providers to reach these women, Medicaid provider offices, and billing workers, with our WIC programs and with high school guidance counselors given these women's ages. We're going to be continuing with our social media communications and working in community locations to try to reach these women. And we're also going to be working on point-of-sale approaches. So as we continue to move forward, we'll keep everyone updated in terms of our progress here in Georgia. We're really looking forward to World No Tobacco Day as an opportunity to get some additional messages out to women. So with that, I will stop, Josh, and turn this back over to you.
Thank you so much, Dr. O'Connor. Our next presenter, Michelle Hirsch, is the Women's Health Coordinator in Region 5 for the Office on Women's Health in the Department of Health and Human Services, where she began her tenure in 1996. Before joining the Office on Women's Health, Michelle was on faculty at Rush Presbyterian St. Luke's Medical Center in Chicago in the Department of Preventive Medicine, focusing largely on women's health and cardiovascular research. Michelle is also a huge proponent of understanding the impact of trauma on women and girls and promoting trauma-informed approaches across all sectors of health, social, and all public services. Welcome, Michelle.
Thank you. I'm delighted to be here today among such a terrific group of speakers and a large audience, obviously, across the country that's very interested in this issue. I want to start off just by telling you a little bit about my office. I work for the Office on Women's Health, and we are in the U.S. Department of Health and Human Services. The vision of our office is that all women and girls achieve the best possible health. We do this through advancing policy, educating the public, educating professionals, and supporting model programs. Clearly, smoking is a huge preventable risk factor for just about everything, every core health and social concern you can think of, as well articulated by the previous speakers. But I'm going to approach it from a little bit of a different perspective here today. I want to talk about the impact of trauma on women and girls, which is really what I do kind of 24/7, because I really do believe it's such a foundational issue that has a dramatic impact on health. So when we're talking about trauma, a very functional definition I use is that trauma occurs whenever an external threat overwhelms an individual's ability to cope. And it's non-consensual. It is the victim feels discomfort, fear, they feel intimidation, they're concerned about their bodily integrity or that of somebody else they feel might be threatened. Some of these effects of trauma include, in the short term, an inability to cope with normal stresses of daily life, difficulty trusting others, emotional issues, attention and memory problems, behavioral issues. Ultimately, it can cause altered neurophysiology, particularly if the trauma happens at an early age, and ultimately a good bit of health impairment. So how common are traumatic exposures? And I like to say that I really am a fun person. I don't just wallow in talking about all these awful things all the time, but I really do feel like it's important for all of us to get a good grip on how prevalent all these violent and traumatic events are in our society. And so this part of the presentation isn't intended to bum you out, but to more bring to your awareness that these things are happening a lot. Hopefully with some of that awareness, we can work to destigmatize and also understand what's behind behavior for a great many people, and understanding what their experiences are. I promise I'll move past the gloom and doom and move towards more hopeful approaches, such as trauma-informed care and trauma-informed approaches. But right now, I think it's useful for us to get on the same page about the world we live in. That said, with respect to rape and sexual assault in the U.S., about 1 out of every 6 American women has been a victim of a rape or attempted rape in her lifetime. Child abuse in the U.S., there are over 3 million reports of child abuse every year. That involves in excess of 6 million children. That's annually. And in the United States has one of the worst records among the industrial world with respect to child abuse and neglect. Intimate partner violence. About 1 in 3 adult women experience at least one physical assault during their adult life in partnership, in their romantic relationships. Men who've witnessed abuse as children are twice as likely to be abusers as adults. Girls who've witnessed abuse in the home when they are growing up are more likely to stay in abusive relationships as adults. And more than 50% of batterers also victimize the children of their partners. With respect to child sexual abuse, I don't think that there is a more closeted issue. I think that people want to believe we live in a just society, and so it's very difficult when we hear about childhood sexual abuse. But we do know that it is the most underreported type of abuse of children. And by the age of 13, 2 in every 10 girls, so 1 in 5 girls, and 1 in 10 boys are sexually abused. Trauma with respect to natural disasters and terrorism, it's impossible in this 24-hour news cycle that we're not always bombarded with the traumatic events that are happening around the country and certainly around the world. And with things so profound as some of these tornadoes of devastation or Sandy Hook, the elementary school shooting, or 9/11, it's impossible to not be affected by it as we see it. Even if we weren't in New York City, for example, we've seen it over and over, the planes hitting the buildings, and it's hard to shake that. I also want to touch on the prevalence of historical trauma. And I'm going through all of this very fast because I don't want to focus exclusively all on how prevalent trauma is, but what it does, what it lays the foundation and the groundwork for. With respect to historical trauma, we think about the situation of American Indians and Alaska Natives who were forced onto reservations. Their culture was taken from them. Many were forced into boarding schools. We know of the abuses that happened there. It's also very relevant to think about the experience of African Americans in the legacy of slavery in this country. All this is to say that it's very common that an individual will have exposure to multiple traumatic events over their lifetime. We've also heard about, many of us have heard about toxic stress, and what is the relationship with that with trauma? Well, we all have experienced positive stress. That's the stress that gets you ready to do a presentation or gets you on time to work. Or then there's tolerable stress, which may be either financial stress in the home, or it might be, having challenges at the office, or maybe it's being in school and academic life is difficult or school social life is difficult. But those are buffered because there are some supportive relationships there to help us. What we're thinking about when we talk about trauma is the toxic stress, which is the prolonged activation of the stress response system in the absence of those protective relationships. So that could well be working in a hostile work environment. It could well be prolonged experiences of poverty or living in violent neighborhoods. Those have very similar characteristics as other traumatic exposures. So what happens when we are subjected to a traumatic event or toxic stress? Well, essentially, our brain undergoes some structural remodeling. Essentially, it's really great. The fight or flight built in that's innate to us that is very useful when we're being chased by a bear. And it allows us to, either climb a tree, or I guess that's probably not a good idea, but running away. It allows us to do what we need to do in a moment's notice without a great deal of thought. It allows us to jump out of the way of a car, to protect our children without thinking if there's an imminent dangerous threat. But the problem is with trauma and toxic stress is that those systems are activated over and over and over and over. And so what that does is when we are stressed, the stressor activates the amygdala. It has an impact on what's called the HPA axis, which is the hippocampus, the amygdala, and the prefrontal cortex, which causes the release of cortisol, and then our heart races, blood goes to our muscles, our digestion shuts down, and our memory is impacted. Now, that's good in those short bursts when absolutely needed, but if it goes on for a considerable period of time, we see structural challenges and impairment in all areas of our body. We know that no area of our body is unaffected by stress. We know that our brain and our nervous system, our muscles, our joints, our heart, the whole digestive system, and the reproductive system. We know that women under tremendous stress have a very difficult time conceiving or carrying pregnancy to term. And so we know that these are areas that we want to look at and figure out how, in fact, we can mitigate some of the impact of trauma. All of this to say that the impact of trauma is dramatically underestimated and really is only gaining some traction as of late among people who are talking about how to address it, how to recognize it, how to talk about it, and so on. So some of the behavioral aftermath of a traumatic event may include anything from difficult to trusting others, isolation, problems with missing classes, work, or appointments, and then also using alcohol and drugs as a way to cope. And I would add cigarettes to that as one of those drugs. Some of the psychological aftermath include, disbelief, numbness. For women in particular, shame and guilt or self-blame, anxiety, depression, sadness are all challenges experiences that people have after a traumatic event, as well as difficulty concentrating. Some of the long-term consequences include everything you can think of that would be captured under mental health, physical health, behavioral health, and ultimately early mortality. So really, I want you to think about what is the relationship between trauma and poor health outcomes. And to describe this a little bit further, I'm going to talk about the Adverse Childhood Experience Study extremely briefly. This is a study, and normally I would say raise your hands if you've heard of the ACE study, although I don't know if this has a raise your hand function, but even if it does, if you haven't heard of it, if you're going to take one thing away from my talk, go and make sure you look up the Adverse Childhood Experience Study. It's also known as the ACE study, and it really changes the course of so many people's careers when they understand these relationships. In short, it was a study of a retrospective study of over 17,000 individuals at Kaiser Permanente in California. And the data on it continues to be analyzed. The original study was 17,000 individuals. To date, it's been replicated in over hundreds of thousands of individuals. And essentially, the takeaway message from the research is that there's staggering proof of the health, social, and economic risks that result from childhood trauma. And keep in mind, there are lots of other types of trauma other than just childhood trauma, but this is just looking at 10 particular childhood traumatic experiences. 5 of them personal, and 5 of them related to other family members. And the 5 that are personal include physical, verbal, or sexual abuse, and then also physical and emotional neglect. You get a score of 1, not if something happened just once, but it's recurring abuse. So you may have been verbally abused every day of your childhood, and that still gives you a score of just 1, just to give you a sense of the magnitude of these issues. If the other 5 are related to family, your family environment, so if you have a parent who's an alcoholic, a mother who's being treated violently, a family member who's in jail or prison, someone who's diagnosed with a serious mental illness and is untreated, and the disappearance of a parent through either divorce, death, or abandonment. This isn't divorce where there's still contact, the total absence of that parent. What they found in the ACE study is that this kind of childhood trauma, and just looking at those 10 alone, is extremely prevalent. 67% of the population had at least one of those things happen to them as a child. We know those are common things that happen. What's stunning is when you start looking further. 1 in 4 people had an ACE score of 1. On up, you get to people who've had experienced 3 of those ACEs. That's 1 in 10 people, so that's a big chunk of the population. On up to 11%, or 1 in 9 people, have an ACE score of 5 or more. And women are at greater risk, 50% greater risk of having an ACE score of 5 or more. So when we get to the levels of 4s and 5s, ACE scores of 4 and 5, that's what we call complex trauma. And the impact is actually cumulative. What they found in the study, looking retrospectively, is getting the ACE scores for these 17,000 individuals and looking at some of their behavior as they've grown into adults, they saw, without a doubt, links and direct relationships among your ACE score and all of these issues, including adolescent health, teen pregnancy, smoking, alcohol abuse, and so on. So let me just run through a few of the slides very quickly. I don't mean to bombard you with data, but what I want you to notice is the progression here. From an ACE score at the left of 0 up to an ACE score of 4 or more to the right hand, you see right here we're talking about depression. And this is critical because smoking and depression are very clearly linked. So the red bars are women, the yellow bars are men. You see a progression, higher ACE score, higher levels of reported depression. Smoking, dramatic increase among the graph as the data as far as smoking goes. More adverse childhood experiences, the greater smoking. And let me just walk you through what has been proposed as the mechanism. Why are these associations? If I had more time, I would show you 20 different slides where almost anything you can conceive of as far as a health or social condition, behavioral health, physical health, mental health, has a direct causal relationship between the ACEs, a high ACE score, and higher prevalence of that particular situation or disease, disability, illness. So let me walk you through this very quickly. So you start at the bottom with an adverse childhood experience. Let's for example, say it's a young girl, she's 9 years old, and she has been awake all night because she heard her mother being abused in the room next to hers. She knows she can't go out and defend her mother. Perhaps the partner, her mother's partner, her father, may have been drinking, and she knows that she's also at risk. Her mother's told her to stay in the room to keep herself safe. So she then, by the grace of God, ends up at school the next day. And do you think she's really going to be that engaged in school? Is she going to be in a mindset where she can learn? Is she going to feel like talking to her friends and socializing and having fun? Where is she going to be? What are the teachers going to think? Are the teachers going to think, oh, she may have had some difficulties last night? Are they going to say, oh, this kid's checked out, disengaged, ADD, lazy, online, playing video games all night? Without this information, they'll probably make those types of assumptions. But with this information, you start to look at the world and people's behavior a bit differently. So that girl then leaves school, has been getting not only fear from what happened the night before to her mother and fear of her father, But now she's been chastised by her teacher. Her friends aren't wanting to hang out with her because she's not much fun when she's like this. And so she's seeking relief. The thing about humans is that we are amazingly good at finding ways to help bring ourselves back to steady state. And those things include everything from smoking, drinking, risky sex, you name it. Those all help us get through the day. But, of course, those what we call high-risk behaviors also lead to disease, disability, and social problems, and ultimately with an ACE score of 6 or more, earlier death. So what I want to talk about is the psychological distress, the relationship between psychological distress and smoking. It's very clear that there's an underlying mechanism that links adverse childhood experiences to smoking. And it's particularly among those who suffered emotional or physical abuse or neglect as a child. So are we talking about high-risk behavior, or are we talking about coping mechanisms? Well, let me just quickly wrap up just a few more slides here about the brain and smoking. So why is this relevant to smoking? When a person smokes, a dose of nicotine reaches the brain in about 10 seconds, and that stimulates the dopamine release in the brain, which triggers positive feelings. And so we know that stress and anxiety in college students are very, very common, and that students report that they use tobacco to deal with anxiety. Anxiety, again, a reaction to trauma. You can see this little cycle of, stressful situation. You smoke, you get some relief, the nicotine withdrawal happens, you feel more anxious, and then you smoke to relieve that anxiety. We know that there's huge relationships between depression and smoking, and that smoking is used as a method to address and deal with smoking among college students. And again, revisiting the dopamine issue, depression, nicotine, and dopamine. Dopamine is involved in triggering those positive feelings, and nicotine has that effect to mimic that dopamine response. So also we can't ignore the weight management consequences for women who smoke. It's an appetite suppressant. Essentially, Vincent Felitti was very astute when he said it's really hard to give something up that almost works. If it helps you in the short term to cope, to get by, to relieve your anxiety, you think it relieves your anxiety, you think it helps with your depression, it helps you maintain your weight, you're going to keep doing it. So the implications that I just want to wrap up here with for designing smoking cessation programs are that we need to keep in mind that there may be a trauma history behind this and why people smoke. And in the absence of taking that into account, we're not going to be able to effectively get people to stop smoking. So what I want to say is that it's essential trauma-informed services take the trauma into account. They avoid re-triggering somebody or making them feel guilty about smoking because that may be their coping mechanism. And then they adjust other factors within the practice or the program or the cessation program to help people adjust and maximally benefit from the program. Again, I just want to say that we should presume that traumatic exposure is pervasive and just assume that everyone has a trauma history because you won't be right most of the time. And when you think about people who smoke, instead of thinking what's wrong with you, think about potentially what happened to you that you're using smoking as a mechanism. I won't get into this. This is the trauma-informed care pyramid that talks about different levels of developing a trauma-informed care approach. The foundation, of course, is understanding patient-centered communication. And I conclude with this information, and if you want more information on trauma and the health effects of trauma, I'm always eager to talk about it. So thank you.
Thank you so much, Michelle. We are going to speed this up a little bit. Finally, we do have Emily Claymore, who is an ORISE Fellow in the Office of the Assistant Secretary for Health in Region 9 and an advisor for the Tobacco-Free College Campus Initiative. Take it over, Emily.
Thanks, Vidisha. Can you hear me?
Yes, we can hear you.
Great. Fantastic. Okay, so the TFCCI is the national initiative to accelerate the elimination of tobacco use on college campuses everywhere. It was actually created in 2012 in partnership with the U.S. Department of Health and Human Services, with the American College Health Association, and the University of Michigan, with lead sponsorship from the American Legacy Foundation. Would like to point out that the initiative does offer campuses technical assistance for whatever stage of the policy process you're in. Our website is a terrific source for resources, as are our advisors, who are always available to answer your phone calls or emails. We also offer a one-day stand campaign, and this is a great way to raise awareness around tobacco-free policies. We provide toolkits, ready-to-go materials to assist you in hosting at a campus event, and we promote this every March and every November. Last but not least, we do have a challenge, and this is a great way to get recognized for your strong smoke or tobacco-free policies, and we are working to get the recognition to campuses who meet certain criteria. Next slide. Being a part of this initiative is a great way to stay connected to funding opportunities. Right now we are promoting our sponsors a funding opportunity for the community college grants. More information is there and on their website. Next slide. The initiative is also a great way to access other valuable resources through the Department of Health and Human Services. One in particular is the CDC's Office of Smoking and Health. A variety of resources are offered here specific to today's webinar topic. We have fact sheets, infographics that highlight the serious harm women suffer from smoking. In addition, they have the Tips from Former Smokers campaign, where you can access media communication materials, website buttons, a whole bunch of other things that are available for your promotion, available all for download. You can also receive monthly emails that have all of these regular updates provided to you. As was mentioned earlier, next slide, I just want to remind everyone that the Office of Women's Health is the lead behind National Women's Health Week. And this is another great source of information for you. And we encourage you to reach out and find your region's Women's Health Coordinator by using that link provided. I just want to wrap up quickly as we are out of time, but I do want to encourage you to visit our website. If you haven't already, sign up for our challenge. Next slide. And maybe even follow us on social media. Definitely stay connected, and as a reminder, we will have all of these slides and all of these resources posted to our website following this webinar. Thank you, everybody.
Thank you so much, Emily. And thank you to all of our wonderful speakers today for your compelling presentations. We ask that you remain on the line for our Q&A session, which will begin in a few moments. I do also want to take this time to apologize for the sound quality issues we were having today. We will send you an evaluation soon, and we ask that you complete it so that we may address all of your concerns for the next webinar and so that we may create better webinars for you in the future. Again, to those of you listening in, if you would like to ask a question, we still have some time. Please submit via the webinar function, Q&A function on top of the screen, or via Twitter at TFCCI, or text them to 412-438-3224. I also want to take a minute to thank my colleague Joshua Prasad, ORS Fellow in Region 3, for his help with this webinar, including handling all the technical and social media aspects. So thank you, Josh. Okay, so we will go straight to our questions. We have one here from a participant for Dr. O'Connor. How would you encourage providers to prescribe tobacco cessation treatment? Dr. O'Connor, yeah, go ahead, sorry.
Can you hear me?
Yes, we can.
Great. So we here in Georgia encourage all providers of any kind, including community pharmacists, dental providers, and others, community health workers, to ask patients about tobacco use, to advise them to quit, and to refer them to cessation support services, and specifically to, here in Georgia, to our tobacco quit line. We have a fax referral tool for providers that use an EMR, and in your state, my guess is your quit line does as well. Or they can simply give the patient the quit line phone number.
Great. We have a question here for Maria. One of our participants wanted you to clarify a little bit more about how menstrual cycle may affect cessation attempts and success. Is it best to avoid a quit date during menstruation or during the premenstrual cycle? Maria, if you
Sorry. According to the studies that I have read, it is best not to try to quit during the premenstrual cycle. So you want to do it in the luteal phase of the cycle. So it's after menstruation begins.
Okay, great. Again, for Dr. O'Connor, what kind of point-of-sale approaches are you using?
We are just launching our point-of-sale work here in Georgia this year. We're going to be training some of our local public health staff, our chronic disease prevention and health promotion staff that work out in our public health districts to do interventions at the point of sale. And those interventions may include reminding convenience store owners, for example, of the requirements around the sale of tobacco, addressing whether there's signage around checking ID for persons under the age of 26, and so forth. And we think that's important because probably in other states you may have observed this as well. You know, there are young adults and youth, boys and girls, who are able to purchase tobacco, although illegally, and with some of the marketing that is directed at youth, you know, it's really at that point of sale by partnering with retailers that we believe we can have a significant impact on youth access to tobacco here as the next step.
Great, thank you so much. We have a question here from Michelle. It was stated to not take away a coping mechanism without replacing it. Did you mean with stress management techniques or support group, or both?
It's different for each individual. If you find something that works, you ask people what's helped them to cope in the past is a good approach. For some people it's dancing. For other people, they find meditation or yoga useful. It could be a whole spectrum of things because one size does not fit all. But to try to take away somebody's coping mechanism without replacing it will likely just increase the stress in their lives, and you know, they'll continue to smoke or drink or do whatever it is that provides them with relief.
Okay, thank you, Michelle. We do have one last question, I believe, for Dr. O'Connor. It seems that a little over 50% of the Georgia smokers were pregnant and continued to smoke ages 15 to 30. What ages were the nearly other 50%?
I'm sorry, can you repeat the question?
Sure, and I apologize if it's not clear. The participant asked, it seems that a little over 50% of the Georgia smokers were pregnant and continued to smoke. What ages were the nearly other 50%?
So of the women who we believe continued to smoke the entire duration of their pregnancy, right, almost double that number were smoking at the beginning, and who were those quitters? That's a great question. I don't have those data off the top of my head, but thank you for that idea, and we will go back and take a look and see if we can compare. If I recall, and I may not have this exactly right, but I do believe when we were looking at those data, those women were older, more likely to be married, more likely to have a higher income. But we will go back and check on that, and I'm not sure if there's a mechanism to follow up with this audience, but if there is, we'd be glad to do that.
Yes, we will be able to follow up and send them the response once you have it. So on that note...
Can I say one thing? This is Maria.
Absolutely.
Yeah, I just want to clarify my response about menstruation and quitting. Just to get to the bottom line, women who quit actually during the follicular phase, which is day 2 of menstruation to day 15, have better luck than if they try to quit before their next period. So follicular phase, day 2 to 15, is the best time to stop smoking. Thank you.
Great. Okay, and on that note, I think just want to thank all of you again for participating and to all of our presenters for being here. And I'd like to take this moment again to remind you to please fill out the evaluations that we will send to you shortly. That will help us greatly in providing better webinars for you in the future. Again, thank you all so much for participating, and we look forward to our next webinar. Thank you so much.